Thank you, Kyushu. And I'm very pleased to be here. It's my first time to be this conference. So I'm glad to give you some update information about brain image study. As Kyushu said, I devote in brain image study for more than 20 years, but my major study was in receptor image by positron emission tomography. I think we, as a clinician, we received so much information about the brain image nowadays, since we hope we can use brain image as a clinical tool or guide to us. But unfortunately, it's not for bipolar disorder, because the bottom line is we don't know bipolar disorder at all. So how come we can have a good brain image study and brain image data to help us to make a right diagnosis? So today I would like to give you some viewpoint from clinician. Although I'm doing the receptor image, but I think that's very important. That is a bipolar disorder. I don't want to get into detail, but actually bipolar disorder is a four-dimensional illness. It's the only one has this so complicated clinical course. As we know, we should think about the frequency of episode and the depression manic episode and the dimensional symptoms and the severity of these symptoms. So it's very complicated. The high misdiagnostic rate bipolar disorder has been proposed and reported in many publications. One problem is we cannot define the several key issues to make a right diagnosis. First is we cannot define clearly the boundary of symptoms. The second is we still cannot explain the subthreshold dimensional symptoms. And of course, we know bipolar depression is different from unipolar depression, but we use the same diagnostic criteria for both. So that result in we cannot make a clearly differential in clinical symptoms, and then how come we can do the brain image study? So that is a very interesting question. But of course, by the advanced technology, we can use like a positron emission tomography or single photon emission tomography. We can do the FDG study to see the glucose metabolism, and we give the specific radioligand to see the specific receptors. But of course, we can use the MRI and to run 4 types of image style, include the structural image, functional connectivity, diffusion tensor image, which can predict the myelin sheaths, and of course, you can do some biochemical marker like NAA for the neuron function. But I still remember yesterday, Professor Greenshaw says, nowadays we are doing so many studies, and even we try to use machine learning, and but one bottom line is garbage in, garbage out. So we should think about our data quality. But you can see, we have once we have a new technology come out, we will use this new technology to give a very short publication, maybe in 10 or 20 cases, and we publish it. And then this machine will become very popular, and we increase the size. And a lot of articles published, and then we can do meta-analysis, and we found something changed. And now we need even more larger sample size to do the machine learning. But you know, they are very expensive. But so how come you can do this in a very large sample size? So that's a very difficult question for clinician. So before I get into detail, I will give you some representative papers, and some of them are coming from my group. And I just want to show you how difficult in this one. And lastly, I will give you my viewpoint and how to improve our research and the future strategy for brain image study. So of course, before brain image study, we should answer these questions. So everybody wants to find a change can be the endophenotype marker. And of course, somebody will ask if this marker is a state or a trait marker. But currently, we are trying to find the trait marker. But somebody says sometimes in bipolar disorder, we need a state marker like a bipolar depression. If the marker is different from unipolar depression, then it's good to guide us how to treat our patient. But as I just mentioned to you, bipolar depression and unipolar depression, we use the same criteria. So it's not possible to do that. But of course, one image marker needed to have the characteristics of a specificity. So we needed to know if this marker can be different between schizophrenia or bipolar disorder, or even we can find it's a bipolar 1 or bipolar 2 or psychotic bipolar or non-psychotic bipolar. I think that's all very important for us to guide us for the clinical treatment. So how come we can have this without this specific aim and we perform brain image study? Therefore, you always get the controversial result. So I would suggest if we go to brain image study, we should have a very specific aim. And even more detailed, I will talk to you. So this is the first paper I presented to you. It's they try to find a brain image change, but in the first degree relatives. But of course, you can find some like inferior frontal cortex. They found the abnormalities in activation by psychological challenge paradigm in functional MRI, but they can find this abnormal activation in bipolar patient and in their first relatives. So it's a big review article, but it's still a bit confused and controversial, and you cannot clearly define an area. Of course, this is another article in bipolar disorder. They try to find some changes if it's a state or trait marker, and you can find this altered activation in different brain regions. But most of them focus on limbic area and in the frontal cortex, particularly in the inferior frontal cortex. I will talk to you about this connectivity loop later. So that paper, it has a very specific aim. So sometimes if they want to find it's a state or trait marker, they can find in their relatives, or they can have this study design with a patient when the patient get a euthymic state, depressive state, or manic state. But you know how difficult to do that. It should long-term follow up this patient. But some of articles, they are doing that. They just want to define these abnormalities is belong to state or trait marker. So this is another study. They try to put this study and try to find out if this change of brain, like a structure or functional connectivity, is different between schizophrenia and bipolar disorder. And of course, you can see it's a structure MR image. We can find a lot of articles that shows it's consistently reported in schizophrenia, has a volume reduction, but some of them are different in bipolar disorder because they argued if the patient received lithium treatment, maybe they can keep the original size of hippocampus. But in generally, the previous brain image study, they showed that the brain volume reduction is more general and generalized, widespread in schizophrenia than the bipolar disorder. We published this paper in bipolar disorder several years ago and has been cited by ICD-11. we try to find out the serotonin transporter, if it's different between the bipolar 1 and the bipolar 2. In this study, we found in bipolar 1 study has a very significant reduction in serotonin transporter, but not in bipolar 2. Bipolar 2 has a very similar amount of serotonin transporter with healthy volunteer. So that's our finding. And this kind of finding was also get a quite consistent concept, but they use different image tool, like the MRS, it's a biomarker, and they can find this bipolar 2 disorder actually is quite similar with healthy volunteer, and this biomarker is less than bipolar 1 disorder. So this is very interesting, and we just replicate the same concept with different image tool. So of course, voxel base is very important, and some groups, they try to differentiate the bipolar disorder and the unipolar depressive disorder. You also can see some changes, but it's inconsistent result. This some paper, they try to find out this like a serotonin transporter in bipolar depression and unipolar depression, and they can find some changes, and they try to use serotonin transporter image to differentiate unipolar and the bipolar. I think that's also most important part for the clinician. Of course, another important point is the switching effect of antidepressant. That bothers clinician very much, because we know I think every clinician in your clinical practice, you can find one or two in your life, but it's not in very big size. So when we check the meta-analysis to see the antidepressant-induced switch to manic, it's always tell you it's no significant statistic significant. But I think every clinician, you can find one or two cases in your clinic. So this is a paper to discuss about the reason to cause switching in Journal Clinical Psychiatry. Of course, I just want to show you, it's a very busy slide, but I just want to show you actually the switching effect is very complicated. It's still very difficult to predict since the sample size it's very small. And in my group, we image serotonin transporter, and to follow patient 20 unipolar depression, but none of them get the switching. So that's really difficult to do that. But of course, by the brain image study, you can see some pathological change, like the frequency of manic episodes can cause significant brain volume, particularly the gram matter reduction in the bipolar disorder. So that's why we needed to give our patient prevention treatment, because prevent manic episode could rescue or protect your brain volume reduction. Yeah, for psychosis, nowadays I think most of the complicated treatment guideline is a bipolar disorder. We can give the mood stabilizer, we can give antidepressant, we can give antipsychotics. So this paper published quite early, but they use a PET study to measure the dopamine 2 receptors, which is very important for the pharmacological effect of antipsychotics. And they found the dopamine 2 receptor actually is increased in the psychotic bipolar, not in non-psychotic bipolar. So this finding make us comfortable to use secondary secondary generation of antipsychotics in the treatment of psychotic bipolar disorder. Yeah, so for the future strategy, I would propose 3. The first one is maybe we should even more specific aim. As we know, this manic study, manic episode, actually, if we want to diagnose the manic episode, we should retrieve at least 3 of the 7 items. But if you compare the 7 items, you can see your right side, they belong to different groups. Some of them, they are cognitive dysfunction, and some of them are behavior, and I just quote the number. So now in my group, we focus on these dimension symptoms, and we can use different methods to do analysis. Then probably we don't need to have a so large sample size and try to explain single questions. So that's the functional connectivity. Most of the studies have shown in the dorsal part, it's more like a cognitive function. It's a dorsal executive function, which has been shown a lot in the bipolar disorder. That's a cognitive dysfunction. In the ventral part, the yellow part, that's more emotional. Yeah, they are more emotional affective processing. And we can use this connectivity to match with a specific clinical dimension. And of course, you know, the functional MRI has a lot of methods to analyze, like we can use seed analysis, we can use different starting point, and to see which connectivity is more related to the symptomatic dimension. The second one is nowadays we have a new machine, but even more expensive is PET MRI. In my hospital, we install this system. But of course, as I know, a lot of hospital, even they install this system, but they are still tuning these parameters. So not so many groups they have done this successful, but this concept I will give you in the afternoon session in our brain image section. So people can lie down in the machine. We can do PET MRI simultaneously, but of course you can do anything you want. But this is a very good paper published in Journal of Neuroscience, and they do this functional connectivity with radio ligand PET image to measure the release of endogenous dopamine. And they give the reward charge paradigm. So see how complicated we do several things in the patient. So we give a psychological challenge paradigm, we measure the functional connectivity, and we even do the receptor image, but indirectly we can measure the release of endogenous dopamine. So it's a more technology advanced. But of course, last point is in terms of the clinical clinician, we still need to have a good classification of patient. So I prefer and I like to have this staging concept. I think you can find the article. But now in my group, we try to put our patient and scan their first degree relative, and we measure the first degree relatives if they are in any staging, and we have this longitudinal follow-up study. It takes time, but we think we can put these parameters together and see if we can explain some important clinical issues. So that's my conclusion is, as we know, this bipolar disorder is very complicated and even difficult if we want to enlarge our sample size to do more sophisticated data analysis, but still we need to go step by step, and we hope we can use this image study and image data to guide our clinical treatment. Thank you for your attention.